Hello.
Hello.
Hello, good evening, Dr. Peng. Would you like to please check your audio in your presentation?
Hear me? Yeah, can you hear me now?
Yes, you're audible.
Yeah, so it's clear.
Yeah, very clear.
Thank you. Perfect. Let me know when you want to allow me to share slides, then I'll try to share my slides.
Yes, please try and share your slides so we can just see that it's all working fine.
Okay. Wait, you have to allow me to share, I think.
Um,
I don't see that section to say share slides.
so can you try?
Wait, yes, wait. Okay. Hang on. Okay, I got it. Wait. Okay, you found it? Can you see it?
Yes. Now we can see your slides.
Marvelous.
Do you probably want to run one of the videos or something and just see that it's working well?
Yes, I will. Give me a sec now. Yeah. Okay. Yeah, it's good. Okay. Thanks for the invitation.
Thank you for coming and joining us. Were you able to run the video and see?
Yes, perfect. It works. Don't worry. Thank you.
Okay, that's great.
Yeah. So you have a regular talk on Tuesdays. Tuesdays with teachers, right? No, I can't hear you. Your voice is mute, I think.
Dr. Kalpana, I can't hear you. I don't know whether everybody can hear you. Though you are unmuted, but can't hear you. Meanwhile, good evening, everybody. Dr. Pal here.
Yeah, I'm here. As long as you can hear me.
Yeah, we can hear you. I can hear you. Yeah, can't hear Dr. Kalpana. Ah, Ashima, can you mute everyone except for Dr. Kalpana and Dr. Peng?
Dr. Chenchal, can you listen to me now? 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 ये क्या हो रहा है? This echoing. Dr. Chenchal, am I audible?
You're audible, Dr. Kalpana, but I think you're zoom in two places. So one earlier one you can leave because it's echoing. Now you're connected by two devices, seems. Yeah. The current device you can continue. The earlier device you can stop.
Oh, okay. Oh, okay.
Yeah.
Is it okay now?
Yes, yes. Perfect.
Okay. Unfortunately, I'm using my phone because the one on the PC, you guys are not able to listen to me. Hi, good evening, Dr. Pang. Can you hear me, Dr. Pang? Dr. Kalpana Nappar
Yes.
here.
Yes, I can hear you very clearly. Thank you. Go ahead. Yes.
So lovely to have you. I had some issues on the computer. I don't know why. I'm now on my phone.
It's okay. It happens.
Thank you so much for being here. And it's 10:30 p.m. for you there. So late.
Yes.
I really appreciate it. And thank you for the...
No problems, my honor. Thank you
Such
for
an odd time.
No,
It's
not
our
at
pleasure.
all. Not at all. You can see my Lego collection behind.
Yes.
Great.
1 minute to go and we'll start.
No problem. Take your time. No hurry.
Okay, it is sharp 8 p.m. here. So we begin the session today.
I see. Okay.
Very special session. Yes, good evening. Good evening to all. Today we have a special guest here, Dr. Kenny Peter. And the subject we're going to discuss is recent advances in sleep surgery. Actually, there are many sleep surgeons here also in India. And many have specialized in minimally invasive procedures. But Dr. Penny Peter Pang, as all of you know, has pioneered in this field, and he's a very well-known, renowned surgeon all over the world. He's so busy that he's invited almost every month to different zones in this world. And we're really grateful to have you, Dr. Pang. And first, a brief description on OSA. OSA, as all of you know, it's a very complex disease. And since it's multifactorial, the exact etiology is not known. The physical factors as well as physiological factors. Now, the disease, as you all know, causes hypoxemia and sleep fragmentation. And it is a purely upper airway disease. Now, before we treat our patients, we need to know it is for sure obstructive sleep apnea and not mixed sleep apnea, because you will not get good results. So one is to perform polysomnography. So we all do here in India, we do follow, all the protocols. We do DICE as well as sleep studies before and after treatment. And since it's a complex disease and, and it causes a lot of comorbidities also, so we have, it's a multi-speciality thing. We involve pulmonologists, sometimes radiologists, sometimes psychiatrists. Now, if a patient goes to pulmonologist, most often they only get CPAP, or a BiPAP. So these assisted airway diseases, they've been the gold standard treatment for a long time. But of late, things have been changing, and ENT surgeons have been able to give good outcomes in sleep apnea patients because of the newer procedures. And for a very long time, sleep surgeries have been performed, initially UP3s like uvulopalato-pharyngoplasties, radiofrequency or coablation or laser. And, there used to be maxillomandibular advancements, and there used to be, other procedures like palatal implants. I got a chance to be in Atlanta's Sleep School of Medicine. So I did a mini fellowship there for 2 months. And I've been to other centers also. So anyway, now there are other procedures like hypoglossal nerve stimulation, which it's different than this. It's hardly done here because of the cost factors. And there are other methods like transoral robotic surgery. And well, we would like to listen from Dr. Kenny Peter Pang about the recent advances in sleep surgery. And I also would like to know how many in the audience, you can keep typing on the chat box. How do you assess your results? How do you assess your outcomes? Do you do a pre-op polysomnography and compare it with post-op polysomnography? Or you're just going to do some questionnaire like Epworth, sleepiness scale, etc., and then compare it post-op? Or are you just going to leave it to the patient and ask him, whether his quality of life is improved, comorbidities, like hypertension, diabetes, etc. Has he or she stopped taking those medications or reduced doses? There are various ways of assessing how your outcomes have been. But we are still following a polysomnography. How about you, Dr. Pang?
Yeah, we'll go into all that later. Do you want me to start?
So before that, before you take up, I would like to introduce you. So
okay.
Again, good evening to all the members who have joined. Dr. Kenny Peter Pang has done his MBBS from Singapore, MRC is from Edinburgh, and FRC is from Edinburgh, and FRCSI from Ireland. Masters of Medicine from ENT, and FAMS, Otolaryngology, throat surgery, and consultant currently at Asia Sleep Center. Asia Sleep Center is so well known that he gets a lot of international patients. People travel from different parts of the world to his center, and he has a large number of footfalls. He's a founding member, International Surgical Sleep Society. We would, some of us would like to be new members of the society. And fellow American Sleep Medicine, American Academy of Sleep Medicine. Again, that's an academy, and they have very good conferences going on now and then. Member of Singapore Sleep Society, member World Sleep Society, member British Association of Sleep Surgeons, member European Academy of Sleep Medicine, fellow Academy of Medicine Singapore, member chapter of Sleep Physicians Academy of Sleep Medicine Singapore, an associate of Journal Otolaryngology Head and Neck Surgery. I was discussing recently with him if some of us can, publish a few articles in his journal. And is an honorary member, International Master in Innovations and Excellence, Upper Airway Surgery, Sleep Apnea from Italy. So welcome, Dr. Pang. It's
you.
we're delightful to having you here, and we really appreciate considering the time zone. Thank you.
Thank you.
Over to you.
Yes, thank you very much. Thank you for inviting me. It's really my honor, actually. And today I want to talk about the recent advances in terms of the new, not so much technologies or surgeries, because we're all surgeons here. So it's like a cookbook. You're so experienced already that you kind of watch a YouTube video and you kind of know how to do it already, or at least you can start trying to do it. So the more important thing about sleep apnea is not just the surgery, which I will show you some, but why you do things and not just how you do it. Because the important thing is to understand in our practice why we're doing certain things and whether whatever we're doing is ethical or not and it's the right thing to do, okay? So actually, today I just wanted to show you, I have no financial disclosures. This is my course that's coming up this July 30 and 31, 2 months time, okay? You can email me if you're interested. So these are the things that I'm going to run through with you today. It seems like a lot of words, but I'm going to briefly share with you what are the more important things, the succinct points from all these. Okay, first of all, the philosophy for treatment, hypoxic burden, is snoring genetic, awake disordered breathing. We hear about sleep disordered breathing. So we want to talk about awake disordered breathing. We want to talk about just the nose in sleep apnea. How about the truth about CPAP? And is surgery really successful or not? It's exciting times for upper airway resistance syndrome because a lot of ENT surgeons miss it. So we have a new classification which I want to share with you. And of course, the sleep goal index, okay? And the prime time is whether Ozempic works, right? Okay. I may not go into that all tonight, but I'll share with you nonetheless, okay? So obstructive sleep apnea is not just an airway disorder, okay? It's not an airway disorder because an airway disorder is just the upper airway. Sleep apnea is a systemic disease, meaning it's like systemic lupus erythematosus, SLE. It affects the whole body. It's not just the airway. The airway obstructions is just the beginning of obstructive sleep apnea, and most of it is a systemic disease, okay? So that sleep apnea is not just AHI, because AHI doesn't tell you anything. None of your patients come to you and say, hey, doctor, my AHI is high. Patients come to you with real symptoms, okay? And treatment is not just surgery. It's not just CPAP. It includes oral appliance, weight loss program, and bariatric surgery as well, okay? So the treatment philosophy for sleep apnea is very, very important. Let me share with you what is the real philosophy behind a cure for sleep apnea. I want to share with you, if you actually look at these two patients, right? Look at the patient on the left, which is the white patient, so to speak. AHI of 95. And after surgery, the AHI is 21. This patient has failed based on Scher's criteria, right? Scher's criteria, which is written there. You can read it. And the yellow patient on the right, AHI at 35, after surgery, AHI went down to 17. And this is classified as success. But I want you to think for a while. Intuitively, you know that the patient on the left, AHI of 95, after surgery went down to 21. Who benefited more? Obviously, is this patient from AHI of 95 to 21 compared to the yellow patient from AHI of 35 to 17, isn't it? Intuitively, you know that the patient on the left benefited more, but he has failed based on Scher's criteria. So maybe our criteria is wrong, isn't it? I want you to consider this, okay, this flow chart. The previous president of the United States, Bill Clinton, many presidents ago, he had a cardiac stent put in for ischemic heart disease. But after about 5-6 years, he still needed a bypass. Does that mean cardiac stents are useless? Does that mean we should throw away cardiac stents and straight away go for a bypass? Because we know that it does work, but it may last just maybe about 5 to 10 years, just like soft tissue surgery for sleep apnea. It works, but there's perhaps some form of relapse, maybe 5 to 10 years time the road. Okay, so that's the philosophy of treatment. That's the philosophy we need to understand. Next question is, do snoring children become sleep apneic adults? Okay, we'll try to tackle this question a little later. So treatment is multidisciplinary. This one we know, okay? You know, sleep apnea has been around since 1960s, okay? And we know that in 1960s till now, it's about what? 60 years of a human life. It's almost one lifespan already. So we do have data. We have a lot of meta-analysis. We have a lot of systematic reviews and pooled data. So we should be looking at these things nowadays rather than just doing things based on what our professors say, okay? So we need to look at evidence-based meta-analysis as well. So whatever at the end of tonight's talk, I want you to go back knowing that what we're doing is the right ethical thing that we're doing, okay? That means our philosophies need to be right, okay? So basically, what's new in terms of pathophysiology of sleep apnea? We all know this. We also know that the snoring patient vibrates the whole night in his palate, either anterior posteriorly, laterally, or some form of base of tongue obstruction, okay? So this one we know is an upper airway disease, but it affects the entire body. So it's a systemic disease that you know that all these critical pressures, you're the expert at this. I won't touch so much on it, but I want to share with you that all these critical pressures, arousal thresholds, loop gain, muscle responsiveness is all part of the physiology of sleep apnea, okay? I want to show you this, in secondary school when you were like 14, 15 years old, you study this volume of a sphere. Did you realize that for every 2 millimeters of radius that you create, the volume increases by 8 times? So it's amazing. So you must remember the airway is a 3-dimensional structure. So whatever millimeter that you gain will increase the volume by at least 8 or more times, okay? So this very busy slide, I want you to look at only 2 words. It's called oxidative stress. Can you see the 2 words there? Oxidative stress is very, very important. And there's many, many papers published. And oxidative stress is the 2 words that link upper airway collapse with the systemic illness, which is closely related to what we call hypoxic burden, okay? I mean, I cannot see number of hands that you raised, but how many of you have heard of hypoxic burden? Hypoxic burden is a very, very important criteria, okay? I say that because not many softwares can pick it up. You know T90, right? Okay, for those of you who haven't heard of this, T90 is the duration of oxygen level below 90%, okay? This one you must remember. As ENT surgeons, you are a surgeon, which is perfect, but you can also be a pulmonologist, but a pulmonologist can never be a surgeon, okay? So you need to be as good as your pulmonologist next door. So the T90 tells you the duration of oxygen level below 90%. This is very important. I will be talking about it later on. But the hypoxic burden is actually more important because it tells you the area under the curve. What does it mean? Okay, I just want to show you some studies. This looked at cardiovascular mortality and hypoxic burden, over 5,000 over patients. And we know that the hypoxic burden is the area below this 90% mark. Okay, can you see the hypoxic burden here? So this area on the curve is very important compared to T90. If you look at T90 here, this is 90% oxygen. If you draw a line right across, you imagine that, look at this part first. This T90 here, it just drops below 88, 89%. The duration can be long, but it stays at 88, 89% compared to a graph that has a very deep, profound dip all the way down to 80 or 75%. Can you see this? So the area under the curve is way more important than T90 itself, the duration below 90. What I'm trying to say is that nowadays we have new software that actually reads the area under the curve, hypoxic burden, versus just T90, which is the duration below 90%. So what you need to do is, if you're looking at a sleep test, please try to look at T90 or hypoxic burden, okay? It's really more representative than lowest minimum oxygen saturation. Nobody looks at that anymore, okay? So this is the hypoxic burden. I won't go through with you the numbers because Really, I don't have the time to, but just understand that it calculates the area under the curve, which is very representative of oxidative stress. Next question, the million-dollar question, is snoring genetic? Okay, how many of you think snoring is genetic? And how about, do Asians or Caucasians have a bigger sleep apnea problem? So I'm going to answer you this, okay? Take a look at this photograph. This is my family tree, okay? This is actually my family tree. It is not, okay, because none of them look like me. In fact, can you see this gentleman? Can you see his small little retronectia, small chin and mouth open? This is his son, isn't it? Mouth, chin, and mouth open and small chin. Can you see they look alike? So believe it or not, you tend to look like your parents. And if your parents have a bad sinus problem with mouth opening, you tend to do that as well. What I'm trying to say is that we see a lot of the southern China chin. This is a real thing. You can imagine that because of retronectia, the jaw is small, the tongue has no space, the retroglossal space is very narrow. So we see these sort of patients a lot. These are the patients that we see a lot. And therefore, sleep apnea is a huge problem in Asians compared to Caucasians. Because if you look carefully, Caucasians have a bigger jaw. They may have an obesity problem, but they have a bigger chin, bigger jaw, okay, compared to Asians. That's what I'm trying to say, okay? So, you know, the sleep apnea is a balance between the jaw and the contents, the container versus the contents. If you have a small container, you have no space for your contents, okay? Then you tend to have higher or more severe obstructive sleep apnea. I divide my patients into global patients and local patients, meaning those global ones are those with a global problem. They are obese. Those local ones are those that are actually quite skinny, but maybe they have big tonsils, huge adenoids, or swollen turbinates or things like that. Okay, so these are the local problems. Okay, so this is very interesting. I want you to also, when you look at a patient, always look at the craniofacial structure, meaning that if a patient has a retronectia or macroglossia, please look out for these things, because this term craniofacial load is very, very important, meaning that you know the floor that you're sitting at. I know you're at home right now. So your home floor has a kind of a loading, isn't it? It's kilonewtons per meter square, meaning every floor has a certain amount of load that you can put on it, right? Because if you put a big car onto a floor that cannot take it, the car will fall through the floor, isn't it? So what I'm saying is that certain structures in the face has a certain craniofacial loading, meaning a patient with a small jaw cannot take so much so-called fat or tongue tissue or tonsil tissue in the mouth. If you look at this study, this was published more than 20 years ago. Some patients, right, every little increase of weight or gross weight or BMI, the AHI will increase drastically. Can you look at this blue graph here? If you look at the blue graph, you can see that as the BMI increases a little bit, the AHI jumps up very fast, okay? These are patients with a very bad craniofacial load. That means that for every small amount of fat or tissue that they put on, they immediately jump, the AHI jumps very fast, okay? Very severe. Then comes awake disordered breathing. Awake disordered breathing is a new term, so to speak, because you heard about sleep disordered breathing, but there are some people who actually are not breathing correctly when they are awake. Okay, they are mouth breathers basically, which you already know, okay? So I just want to share with you this animation of a child or a teenager having swollen sinus turbinates and big adenoids, right? Because their nose is blocked, they have no choice but to breathe through their mouth. So they have persistent mouth opening, they breathe through their mouth. Because they're not using the nose, they develop mid-face hypoplasia. The palate starts to arch upwards. And because the tongue drops, there is no tongue to splint the palate. The palate becomes very narrow. It's called mid-face hypoplasia. So the nose doesn't grow, the palate doesn't grow, and therefore the palate's face, the so-called the patient's face actually moves backwards and has this sort of spoon-shaped face. So this is pretty common, in patients with chronic nasal obstruction. We see this a lot. So our idea as ENT surgeons, or our duty, so to speak, is to treat the patient's nose very aggressively. So this is the sort of patients that I see a lot. These are patients with very bad chronic nasal obstruction since childhood, who was never treated, okay? So these are patients who with mid-face hypoplasia. This is what we call awake disordered breathing, okay? So I tend to be very aggressive with my patients with nasal obstruction, especially children. I will do their turbinates, their septum if necessary, their adenoids, just to clear their nose so that they can actually breathe better, so that they learn how to breathe through their nose, so that the mid-face, the maxilla can grow, okay? So nasal breathing is very important. I cannot emphasize this enough, which I'll show you in a short while, okay? You will remember this video, for those of you who, take aeroplanes. Can you see the very nice laminar flow? This is called laminar flow in the nose, okay? This is similar to this, which is actually, can you see the very nice airflow here? This is called laminar flow, okay? So the idea is to create a laminar flow within the nose itself. Can you see on the right side? This is me doing a radio frequency turbinate reduction, and this is the smoke that's coming out, okay? So this is laminar flow within the nose itself, okay? This helps the patient breathe smoothly compared to this, which is turbulent nasal airflow. Can you see turbulent nasal airflow? This occurs when a patient has nasal obstruction or deviated septum. So you get a lot of turbulence within the nasal passages. And with this turbulence, you also get a lot of snoring, okay, because of palatal flutter, okay. So I tend to treat my patients not just the palate, but the nose as well, okay. So airflow dynamics in the upper airway is very important. That's what I'm trying to say, okay. Of course, DICE is very important. You talk about Muller's maneuver, you talk about assessing the mouth, the nose, the turbinates, the septum, as well as the adenoids. DICE is important. I won't be going through everything about DICE with you because of the interest of time, but I just want to share with you, right, that nowadays, with the advancement of surgical technique, right, we can actually look at the types of the patterns of collapse. Can see that this is quite a lateral collapse as well as anterior posterior. So this is the sort of patients that I will do the expansion pharyngoplasty for, okay? Let me just move to the next one. And then this is a patient with a very bad tongue base obstruction, you can see. All right. So these are the patients which you may want to address the tongue base as well, okay? I obviously don't have time to go through with you all the different procedures, which I think is more important to know why we do things instead of how. Can you see the anterior posterior collapse in this patient? This one, I wanted to show you the jaw thrust. At the end of the DICE, I always do a jaw thrust. Can you see that the airway opens up pretty well? Just to remind you that when you do a DICE as well, you should try to, pull the jaw forward to at least see in case you want to prescribe a patient with a mandibular advancement device, okay, which is a MAD. I want to talk about the nose as a follow-up because I want you to understand this phrase. Nose surgery is pivotal, but not primary, okay? I'm going to explain to you what I mean. Nose surgery is pivotal, but not primary. Meaning, if you operate on the nose alone for sleep apnea, for a patient with sleep apnea, you only do the nose, you will fail in terms of success rate. But if you're going to operate on a patient with sleep apnea, the palate or the tongue, please include the nose. Let me explain to you, okay? So we published a meta-analysis, systematic review, 25-year review of nasal surgery is pivotal but not primary. Let me explain to you why, okay? So we know that if you do nose surgery alone, you cannot cure sleep apnea. Cannot. But if you are going to do sleep apnea surgery, please include the nose. You understand where I'm coming from? Therefore, nose surgery is pivotal but not primary, okay? I'm going to show you some evidence right now. We all know that more than 50% of the entire upper airway resistance is in the nasal valve area. Okay, so this is very important where we need to treat the turbinates, the nasal valve, the septum, whatever is necessary, adenoids if needed. Okay, so I want to show you some data. This was published by Stacy's group, okay, from US, and it shows clearly that this, and this is another paper published from Spain, 25 articles, and they looked at the meta-analysis of all these articles, which I don't have time to go through, but I just want to share with you. If you look at all the articles here, you notice my red lines that says that there is no significant change in AHI. All the patients breathe better subjectively, but objectively, the AHI was the same, all of them. That means to say that the nose surgery alone does not cure CPAP, okay? So nasal surgery is pivotal but not primary. Let me show you. So we looked at all these articles, and let me explain to you that if you were going to do multi-level surgery, including the nose improves success rate. Okay, it does. Let me explain to you and show you. So we looked at 735 patients. This is a multi-center trial that we did. We published it in the investigative otolaryngology laryngoscope. Okay, and we divided these patients into those that had no surgery. You can see that these patients had palate, barb, pharyngoplasty, expansion, anterior palatoplasty, UP flap, Z-plasty, and everything. Tongue surgery as well, robotic tongue, and nose surgery. So we called this group the nose group. This group also had barb, palate, tongue surgery, but they did not have nose surgery. So we call this the no-nose group, okay? So we had 575 patients in the nose group and 160 in the no-nose group, okay? So what we did was, we looked at the success rate. And if you look carefully, all those patients in the nose group had better success rate than those patients with the no-nose group, okay? So this tells us that adding the nose is important. Okay, let's move away from the nose and talk about CPAP versus surgery, okay? So this is a very nice landmark paper that was published, 9 years ago, and they looked at 2,700 patients, okay? So they had two main groups, one CPAP group, 1,300 patients, and another group with usual care. Usual care means no treatment, just monitoring, okay? So they followed them up for 84 months, which is 7 to 8 years. And they looked at the incidence of myocardial infarction, strokes, heart failure, TIA, transient ischemic attacks. And after 7 to 8 years, you notice that the CPAP group, all those that use CPAP and all those that didn't do any treatment, was the same. That means it meant that whatever you do, CPAP or no CPAP is the same. So perhaps CPAP doesn't work, okay? This is another study published in Korea. They looked at 22,000 patients who went for UPPP, okay? And if you look carefully, the group with no surgery was 170,000. Those that went through UPPP was 22,000 patients. And they'll follow them up. And you look at those with heart failure, those incidents of heart failure was much lower in the UPPP group compared to those with no surgery. So we cannot say that the palate surgery is useless, because after the follow-up, studies have shown that palate surgery is way better, okay? So we looked at first-line treatment for CPAP. We looked at 69 articles, myself and Brian Rothenberg from Canada, and we looked at over 20 years of data of 82 articles with CPAP, okay? This is the CPAP compliance. Can you see? It's between 30 to 40%. This is over 20 years, okay? And you notice that it's plateaued. Plateaued meaning it's flat. It's the same. And this is even though the CPAP has improved. It moved from manual to auto to C-flex to BiPAP. The compliance rate is still the same. So maybe it is not the CPAP's fault. It is the patient's fault. It's the human fault that is the problem, okay? So we know that CPAP over the 50 years has been the same, not improving. But we know that surgery, palate surgery over the years is improving. It's first started in 1966. Let me show you the data, okay? This was published in 1996. This is by Aaron Scher. This is over 20 over years data, and you look at the success rate is 40%. Al Shang, it published 10 years later in 2007, and look at the success rate of palate surgery, 55%. So myself, I looked at 17 years of meta-analysis, okay? 17 years of palate surgery. We found the success rate to be 67.5%. So it's improving, isn't it? It's improving, okay? If you look at these 59 articles, 2,700 patients, I want to show you something very interesting. The first 10 years, you notice that one quarter, 25% was UPPP. The next 8 years, only 12% of surgeons use the UPPP. And the success rate was increasing. So you know that I introduced the expansion technique in 2007. After that, you notice that less people use UPPP and more success rate. What I'm trying to say is that ENT surgeons became intelligent. We realized that the UPPP is not a good surgery to do, and reconstructive surgery is better, like expansion, barb sutures, lateral pharyngoplasty is better. That's what I'm trying to say. That means that with time, ENT surgeons should evolve to do more reconstructive surgery, okay? And our study showed that the anterior palatoplasty was actually the best for AHI reduction, actually, okay? So we know that palate surgery is improving, okay, which is great. That means that when you do palate surgery for your patients, you must be reassured that you are doing the right thing. I think that's the most important, what I'm trying to say, the take-home message, okay? So does OSA surgery really work, okay? So we know that this is out, okay? We know that sleep apnea surgery is not a UPPP. It is not, okay? It's because you might end up with nasopharyngeal stenosis, okay? And we know that surgical technique is very, very important. I just want to show you some very quick video clips of the expansion technique. For those of you who started doing it, because I introduced it in 2007, it's pretty easy to do actually. And there's so many modifications. Please do it the way that you're comfortable with, okay? This is after a tonsillectomy. This is the palatopharyngeus muscle. So what we do is we make a horizontal cut as inferior as you can. You notice that I keep some of the fibers of the palatopharyngeus muscle behind and try not to buttonhole the posterior tonsillar pillar. And you try to release the muscle so that you create a pool. Can you see the pool? The idea is a tension pool, okay? So that you want the tension to be pulled anterior, lateral, and superiorly. So I use a figure of 8 suture, 4O vicral round body suture, okay? So I put a figure of 8 suture over here, and I stitch it and pull it towards the lateral side. I put my finger behind the palate to feel the direction of the hook of Hamulus. And that's exactly what I do, okay? So I just want to show you so that all of us can see. Okay, and that is exactly what I do, all right? And I tie it onto the, wait, there you go, arching fibers of the soft palate, okay? There's many, many variations. I don't have time to show you, but can you see the pool immediately, okay? If you're not happy, you can take multiple stitches and to pull it laterally, okay? There you go. We have 15 years of meta-analysis. You know, any surgical technique, after 10 years, it will show itself in terms of success rate and complications, okay? We looked at 16 different articles with a pooled data of 747 patients who had the expansion technique done. And we found a pooled success rate of about 80%, okay? So the idea is that this technique works for patients with lateral wall collapse, okay? Lateral wall collapse of the palate, okay? We also looked at other outcomes, not just AHI, which I don't have time to go into, but 12 studies had all shown that even blood pressure improved, Epworth-Sleepiness scale improved, interleukins, tissue necrosis factor, C-reactive proteins all improved, okay? I don't have time to go into, okay? I also wanted to show you the anterior palatoplasty. These are patients with anterior posterior collapse of the velopharynx, a soft palate, okay? So what I do is, you can see that after I remove the tonsils, I actually make a box. This is a square box on the soft palate anteriorly. So it is to pull the soft palate forward, okay? So the idea is to take a good bite so that the mucosa does not tear through. You notice that you do not need to expose muscle. This is good enough. Wait, and there you go. I put about 10 to 15 sutures of the soft palate area so that it will break the tension and then the sutures won't split, okay? You notice that this is the uvula here. Can you see the uvula? I am now a uvula lover. I did not used to love uvulas, but I must say that now I do tend to keep the uvula if it is a small uvula, okay? I tend to keep it. The answer is yes, okay? So this is what it looks like at the end. Can you see? Okay. So you can see that the anterior posterior space opens up. Okay. I've talked about oxidative stress. I've talked about hypoxic burden. I've talked about basically that sleep apnea is genetic. It runs in families. I talked about DICE and the new surgical techniques and how reconstructive palate surgery is more important than ablative UPPP. And I've talked about how we can reconstruct the palate. If you have an anterior posterior wall collapse, I do the anterior palatoplasty. And if you have a lateral wall collapse, you can do the expansion pharyngoplasty. If you have a concentric collapse, I will do both together. Okay, so that's my basic palate surgery. Okay, just to let you know. Now, I want to talk about upper airway resistance syndrome. These are patients with a normal AHI, okay, normal AHI. And we tend to miss out a lot of these patients. Okay, why? Because we don't look for it. In 1993, Christian Guilleminot actually described this already since 1993, 33 years ago, okay? I won't have time to go into it, but I will share with you the million-dollar question: is UARS a spectrum from snoring, UARS to sleep apnea, or is it a distinct entity? I'm going to share with you why it is both, okay? So UARS are patients with normal AHI, okay? I say again, normal AHI. That means the AHI is less than 5. But they have a lot of RARAS, respiratory-related arousals, high arousal index. These patients are always very tired. They have no apneas. Their oxygen level may be normal, but they're very, very tired, okay? So we have the largest series, Asian series in the world, only 86 patients. But these patients also have jaw joint problems, TMJ, okay? So these patients have bruxism and they grind their teeth a lot, okay? Let me show you. We know that sleep apnea, most of them are male, right? They are overweight, they may be obese, they have hypertension. But patients with UARS are ladies. A lot of you ladies out there may have these. They are ladies who are actually very skinny. They are thin. Their BMI is normal. And these patients with UARS actually have hypotension compared to sleep apnea with hypertension, okay? And these UARS, they are not at risk of strokes or heart attacks, but they have a lot of functional somatic symptoms. They are tired, they are moody, they are short-tempered, very edgy, they have higher incidence of depression and emotional instability, okay? These are patients also with allergic rhinitis. A lot of them, 92% of them, have nasal obstruction, headaches, neck aches, and jaw aches, okay? Let me share with you why. Okay, you know, in the old days, the dentist would tell you that teeth grinding, bruxism, is a mechanism due to malocclusion. In the old days, the dentist will tell you that patients who grind their teeth is because at night, the teeth is trying to mold itself to get the perfect bite. So that is wrong, okay? Nowadays, we know that upper airway resistance syndrome is related to bruxism. It's not due to malocclusion. Let me explain to you. Okay, I want to share with you this. Can you read carefully? The collapsing anatomical structure is not always the primary site of flow limitation. This was published by a Japanese ENT surgeons, okay? Basically, they are saying that if the nose is the primary site of flow limitation, that means if your nose is blocked, your nose has flow limitation, right? But the collapsing structure is the palate and the tongue. You understand? I say again. That means if the nose is blocked, the nose has flow limitation, but the side that collapses is the palate or the tongue because of the negative pressure. Okay, so look at this diagram. Imagine that if you are breathing right now, you're sitting there listening to me talk. You create an intra-pleural pressure of -8 cm water. If you have some form of nasal obstruction, nose block, you need to create a -30 cm water, which means you need to create a lot of negative pressure in order to suck air into your lungs, right? And therefore, your hypopharynx or your retroglossal space or your palate will collapse. That's what I'm trying to say, okay? So we know that these patients are nowadays, patients with UARS, they actually have some form of airway collapse. So what happens is that because of the nose block, the nasal obstruction, the hypopharynx or the palate starts to collapse. As it collapses, the brain, the EEG, there is brain cortical arousals, followed by a tachycardia. They call it heart rate variability, HRV. For those of you with good cardiology friends, you must listen to them, okay? The HRV is very important. After this, there is bruxism. So you look at it, bruxism does not cause EEG arousals or brain arousals. It's the brain arousals that cause the bruxism. And the brain arousals is due to what? Is due to airway collapse. Take a look at this again, another polysomnogram. If you look at the polysomnogram very closely, you realize that there is some form of cortical arousals followed by tachycardia and then bruxism. Okay, so which came first, bruxism or the cortical arousals? The cortical arousals came first. That means bruxism is actually a compensatory mechanism to keep the airway open. Okay, you know, every time you bite down, now you can just bite down at home right now. You bite down, your platysmal muscles and your masticatory accessory muscles are all in use, isn't it? So when you bite down, for those of you who can see me in that little small camera corner of yours, can you see me biting down? When I bite down, my neck muscles is all strained, isn't it? That is why these patients with UARS all have bruxism and TMD, which is temporal mandibular joint disorders, okay? So a lot of our patients have this condition called UARS with TMD, okay? So 90% of them have bruxism. 92% of them have some form of rhinitis, which is nasal obstruction, okay? and they have headaches, neck aches, and 68% have depression. So a lot of these ladies are very, very depressed, okay? So these are the patients that we need to treat, okay? This is all part of this thing that I bring you back to what I said just now about awake disordered breathing, okay? They're all linked together, which I have no time to go into, okay? But you notice that these patients have a very high hyoid. You see the hyoid bone here? They all have a very high hyoid compared to patients with sleep apnea, because you know, patients with bad, severe sleep apnea, the hyoid bone is very low. It's called the unstable airway. Whereas patients with UARS all have a very high hyoid bone. Okay. What do we do for these patients? Very easy. The ENT surgeon will do the nasal passage. You can clear it. You can do your turbinoplasty, septoplasty, whatever. And then the dentist will give a mandibular advancement device. Okay, so this is very important. I need you to remember this. Okay, so URS is very, very important. So we looked at a 32-year classification. We just published this actually. And basically is to try to delineate and understand the type 1 and type 2 UARS, okay? Type 1 are those with UARS and temporal mandibular joint dysfunction, meaning bruxism, teeth grinding, joint pains, and things like that. UARS type 2 are those of a spectrum type. That means these are the patients that actually move from UARS or simple snoring to UARS to sleep apnea, okay? So there are two main types. That's what I'm trying to say, okay? So we looked at these, and how many of you have heard of COMISA? Comorbid insomnia and sleep apnea. So this is actually quite a big thing that's coming out, okay, which I don't have time to go into. But it suffices to say that all these are related in one big bundle together, okay, which I have no time to go into. But in a nutshell, this Venn diagram actually shows you how they're all combined together, okay? So this is a new thing that we actually described and is up and coming, okay? So we looked at all these, which I won't have time to go into, but nonetheless, we look at our own data, 18-year review. This is just sent for publication. And we looked at most of them, if you look carefully, are the type 2, which means it is a OSA spectrum, and 41% is the UARS TMD type of patients, okay? Okay. Finally, I need to talk to you about success rate, which is the sleep goal index, okay? So I introduced this new outcome measures about, I want to say 6-7 years ago, just before COVID. Basically, is to tell us that AHI is not good enough. AHI is not the only parameter we look at, okay? Because AHI only tells us the number of times the patient stops breathing, right? But we should be looking at the end organ damage, which means what? Like hypertension, oxygen level, things like that, okay? So we published these current concepts of sleep apnea. Why? Because we know that sleep apnea is not just AHI. Because a lot of times AHI is nebulous. None of your patients come to you and say, hey, doctor, my AHI is high. No, patients come to you with real symptoms, isn't it? And we know that AHI, there's a lot of critique out there that do not believe in AHI itself, okay? Because sleep apnea is a disease load. It's its hypoxic burden that we're talking about. It's a full holistic problem, okay? Now let me explain to you. You know, there is a huge difference between, it's called the 3% rule, right? You heard of it. That means that oxygen desaturation below 3% versus 4% makes a whole lot of difference, okay? Let me share with you. If you look at it, they actually did studies to show that if you tabulate your sleep test and you look at the 3% desaturation or the 4% desaturation, there is a 2 to 3 times difference in sleep apnea severity, you know, just because of 3 versus 4%. It makes a difference, okay? So we know that AHI is not accurate, is misleading, is inadequate. We should be looking at end organ damage. Okay, so sleep goal is very, very good. Why do I tell you it's good? Okay, basically, our first study, we looked at 302 patients lah. Okay, I must thank my authors, of course, because my co-authors actually did a lot of work. Okay, and we looked at this sleep goal. So this is the acronym for sleep goal. All right, so for those of you who like to take note of it, you can, but it's already published, so you can look about sleep goal anywhere on the internet. You just Google it. Okay, then because a lot of ENT surgeons, you know, as surgeons, right, I'm also a surgeon, we are all very forgetful. We say, hey, you know, Kenny, sleep goal is 9 parameters, it's too many. Can you cut down shorter? So we looked at the sleep goal index. I must thank my co-authors for helping me with this. Okay, it takes a lot of effort because we had to collect a lot of patients, 618 patients, multi-center trial. Okay, so we published this in the European Journal of Medicine as well. And we looked at these 4 parameters. Okay, this was also published recently, I want to say just last year. And we basically looked at these 4 parameters here, which is blood pressure, systolic or diastolic, 7 millimeters or more drop, gross weight, a reduction of 8%, or BMI drop by 2 points, oxygen saturation, T90, reduction by 50%, and AHI reduction by 50%. So we looked at basically these 4 parameters alone. Okay, I don't have time to go into it, but we collected over time because it took more than 4 years because COVID at that time, nobody could see any patients, right? So we looked at the McNamara's test. These are all data which I don't want to bore you. So this is all you need to remember. We looked at 4 parameters. End organ damage, blood pressure, BMI, T90, which is oxygen duration below 90%, because hypoxic burden the software was not released at that time. So nowadays we have it. So we're going to switch to hypoxic burden and AHI, okay? So basically we looked at this 618 patients, and I just want to show you that we looked at comparing this 618 patients with Scher's criteria, 55%, and 2 out of 4. You can see that they're very close to 55%, meaning to be deemed successful after treatment, you only need 2 out of 4 criteria instead of all 4. Okay, so that's what we looked at. So we came out with a table. You can download this table. I'll give you the QR code. Basically, we look at this 4, and if the patient after surgery fulfill this one, you can put a tick here and a tick here. Any 2 out of 4 means that the patient is successful. So we use the sleep goal index nowadays, and you can download from this QR code. Okay, it's also on my website. It's drkennypang.com. You can download it here, and a lot of Europeans have used it. And in fact, we published a consensus statement, a European consensus statement, and you can see that almost 75% of all ENT surgeons agree that the sleep goal index is actually more holistic and more comprehensive. Okay, so a lot of us are now moving forward and using the sleep goal index instead of just AHI because it just makes sense. And AHI has too many variables, inaccurate, misleading, and not good for prime time. Okay. Finally, this is just my course. It's on 30th and 31st July this year. And if you can't make it, there is a London course next year in London in January 2027. Okay, thank you very much. Any questions for me? Shall I look at the chat?
Yes, please.
Yeah, okay, let me look at the chat. Wait, let me see. There you go. Okay, wait, let me just get my pointer. Okay, good. Okay. Let me see. Okay, let's go up. Okay. Combination question. Why is... Yes, why is more important than how? Thank you. Yes, yes, genetics is yes. So definitely, sleep apnea is genetic, and agents are more severe. We see lots of complications from untreated adenoids. I agree. I always treat the adenoids if the adenoids are definitely enlarged. Yes, spoon-shaped face. Thanks. Yeah, you can start using it. It's actually quite interesting. I tell my patients that because of mid-face hypoplasia, the patients develop a spoon-shaped face. Yeah. Okay, anterior pharyngoplasty. How do you decide how big in a box? Very good question. Okay, yes. So basically, the rectangular box is, forgive me, try to imagine. I have a diagram, but because I didn't include it because of time, it is a rectangular box that is 1/3 from the junction of the soft palate and hard palate superiorly and the base of uvula inferiorly. You draw a line, you have 1/3, 1/3, 1/3, and the middle third is that rectangular box, okay? And that rectangular box, you try to go as far lateral as possible because some patients' palates are broader than others, right? So you just try to go as far lateral as possible. Okay, what is the advantage of keeping the uvula? Okay, I will share with you that when I first started doing palate surgery in 1997, I've done at least 7,000 palate surgeries, okay? I used to cut off the uvula, okay? I was not a uvula lover. Now, I am a uvula lover because the uvula acts as a funnel, okay? Funnel meaning, sometimes there is patients complain after UPPP of like postnasal drip. Okay, the uvula acts as a funnel. That means if there is any mucus or phlegm behind the nose, it will drip down behind retropalatal area, touch the uvula and form a droplet of water and touch the tongue and you swallow it without knowing. But if you have no uvula, the patient will feel the phlegm dripping down. Then he will say that he gets this like a postnasal drip sensation. That's number one. Number two, the uvula is like an oil canister. Like your false vocal cords, right? The in between is called the ventricle. It's like an oil canister. It does lubricate the palate. Okay, and I will share with you that snoring is not due to the uvula. Okay, it is due to uvula, but it is not always due to the uvula. Okay, that means that cutting off the uvula does not remove snoring. That's what I'm trying to say. Okay, so please do not have the idea that once you cut off the uvula, there will be no snoring. Okay, that's not true. Okay, yes, you're most welcome. I will see you soon, Dr. Sura. You are coming, right? Okay, do I still use palatal implants? No, I do not do palatal implants anymore. I used to in 2003 when I was in Atlanta, Georgia, as well as in Augusta, because the palatal implants do not work. And for simple snoring, I do radio frequency of the palate under local anesthesia. But I tell the patient that he may need 2 or 3 sessions separately, about 3 to 6 months apart. Okay. Yeah. So I do not use palatal implants anymore. Okay. Do we treat UARS surgically? UARS is a very unique problem because these are usually in ladies with a lot of TM joint problems. You must be very gentle with them because, sorry, okay, because they are quite emotional and quite depressive patients. You must explain to them that you need to treat them holistically. Treat the TMJ, meaning the jaw joint. They need mandibular devices, meaning oral appliance or mandibular advancement device. They need to clear their nose, meaning if they have nasal congestion, I will do a turbinate reduction, septoplasty, adenoids, whatever you need to do for the nose, and then refer them to your favorite dentist. Your dentist must be your best friend because he will send you a lot of patients, okay? and some of them need Botox to the masseter muscles because they have a lot of clenching. Yes. So do you treat URI surgically? Yes, but only the nose. Usually, I don't do palate. Okay. Do most UARS patient need nasal surgery? Okay, good question. If the UARS patient does not have nose problem, then you may not need to treat the nose. Okay. But a lot of patients do not know that they have nose problem because they grew up all their lives with a blocked nose. So they do not know what a good nose is. So you need to explain to them. Okay. Yes. Thank you. Yeah. Thank you very much. Okay. Any technical pearls to avoid velopharyngeal insufficiency? Okay. Very good question. So how to avoid VPI, velopharyngeal insufficiency? Okay. Number one, you always remember that you as a surgeon would rather a recurrent snorer than recurrent VPI, right? Okay. So what I'm trying to say is that you need to be very conservative in your palatal reconstruction. I do not do palatal ablation or palatal removal. I do palatal reconstruction, okay? So in order to prevent VPI, number one, try not to reset or cut above the base of uvula. Very important, okay? Number two, you know, when you're doing a tonsillectomy or a UPPP or palatal surgery, when the patient is under general anesthesia, you put the suction to the nose, the Yonker suction. You know the Yonker suction that you use for tonsillectomy? You put in one nose and you use your finger to press the other nose to create a seal. So you are now sucking the nose on one side, and on the other nostril, you close it, and you can see the soft palate falling backwards, as in being suctioned backwards, and you will be able to see the dimple on the soft palate. Actually, I have a video of this. I should have put it on, but you will see a dimple. That is the junction which you cannot go superior of that junction because the patient will develop VPI. Okay, so that is how you tell. So try to be as conservative as possible if you can. Okay, how often do I do tongue reduction? Very good question. So, you know, in general, right, I want to say that any sleep apnea patient, 10 patients with sleep apnea, at least 3 of them will require tongue surgery, at least 3. Sometimes, depending on your season, sometimes 5 of them, okay? So what sort of tongue reduction you to do? Okay, really up to you. Depends on your center and depends on what so-called technology you have. Please do not immediately start doing robotic tongue surgery, okay? Try to start off with simple ones that make you more comfortable, like radio frequency of the tongue base, coblation of the tongue base, coblation channeling of the tongue base. These are simpler techniques which probably will not cause any mortality, as in death, okay? Because I've been expert witness to many court cases, and I can assure you that you do not want, touch wood, to have any mortality from tongue-based surgery, okay? So for those of you who are coming to my course, I will show you videos of all these tongue surgeries and who are the ones that you shouldn't operate on, okay? Okay, next question. Thank you. Do I do barbed wire? Okay, thank you for asking that. Okay, you know, barbed pharyngoplasty is a good technique. However, you must be very careful because the barbed sutures take some time to dissolve, okay? If you look at the data, the complication rate of foreign body sensation for a barbed suture is 7 to 9%. 7 to 9%. Foreign body sensation for barbed suture long term. Long term is about 2 years. So that's the data that's out there. I don't do barb. I used to, but I will share with you that I'm not comfortable with my patients complaining that they feel something in their mouth all the time. And nowadays, I think you all experience it. There's this thing called social media. Yes, so social media is a double-edged sword, okay? That means that it can go positive or it can go negative, okay? So this is something that you need to think about. And for those of you who are coming for my course, I will explain it in further detail, okay? So sorry, yes. Oh, you haven't started? Yeah. So yes, you can use microscope for your surgery, yes, or you can use endoscope. That's okay. But I don't. I do endoscopic surgery only for the nose, and sometimes tongue-based surgery. I use the 70 degrees scope for lingual tonsillectomy. Okay. Yes. Good to see you. Yes. Okay. How we treat primary snoring? Okay. Primary snoring, I usually do it under local anesthesia in the clinic, meaning I do both if necessary. If the patient has swollen turbinates, I will do radio frequency of the turbinates and I will do radio frequency of the palate. I always tell the patient that the patient may need 2 or 3 palate reductions for radio frequency, okay? I tell them that they may need more than one, okay? Yes. Okay, what's my protocol for evaluation of OSA? Okay, this is quite a big question, but I always questionnaires, good physical exam, clinical history. You can do a DICE. I think DICE is helpful. So if for those of you who are starting out, I think you get your DICE protocol well, and you become more confident in assessing the upper airway. And from the DICE, you can decide what sort of palate surgery you want to do. And then you become more experienced doing palate surgery, okay? Yeah, during my course, I will also teach about DICE and how to do it the correct way, okay? Thank you very much. Yes, suctioning the nose, thank you very much. Thank you. Yes. Okay, do I do epiglottoplexy? Okay, thank you for asking. Yes. Okay, for those patients who have a special kind of epiglottis, there are 3 basic types, which I don't want to go into because it's too complicated, but it suffices to say that yes, if you have a trapdoor kind of epiglottis, the answer is that you probably need to do some form of epiglottic surgery, but please be careful because of aspiration. So you only want to take maybe 25% of the top layer of the epiglottis. Please don't take more than that, okay? Because aspiration is also a problem, okay? Okay, how to decide to advise ASAP surgery rather than CPAP or weight loss comparable to age? Okay, very good question. I tell my patients all about CPAP. I tell my patients that they need to try CPAP. It's up to them whether they want to try or they do not want to try. But all of them know that they need to at least see the CPAP in my office. Okay, so I show them the CPAP. I get them to sign a piece of paper to say I refuse CPAP so that they at least understand that CPAP exists. Okay, that's number one. How ASAP do you do surgery? Okay, the sleep test does not tell you what surgery to do. The sleep test tells you how urgent the surgery is. If the patient has severe sleep apnea, I'll tell the patient to buy CPAP or get CPAP tonight or get surgery soon. The DICE will tell you what surgery to do. The sleep test will tell you how fast you need to do the surgery. You understand? Okay, good. Yes. Next question. Okay, what's my criteria for combining multi-level surgery? Okay, good question. So I want to say that depends on the patient. Some patients say, hey, doc, I don't want to do nose, palate, and tongue together. I'm a bit scared. Then I will do stage surgery. But in general, I am a proponent of multi-level surgery. That means I do nose, palate, tongue together one time because it is less risky in terms of general anesthesia for this patient. So I do combine multi-level surgery. The answer is yes, I do. Okay, when do you do surgery for obese patients? Okay, if your patient is really obese, right, I try my best not to do surgery until the patient loses some weight. Okay, because you know, you want a motivated patient. You don't want a patient that comes to you and say, hey, doctor, fix me. I want you to fix me. Because you know that sometimes the patient's expectation of you is too much, too high. So you don't want that kind of patients. You want patients to understand that life happens, that they need to earn the surgery from you. So I get all my obese patients to lose at least 5 to 7% of their body weight first and use CPAP, and then we'll consider surgery. And then I will say that you have earned the surgery. You understand? So that's what I do. So I am very, very careful with obese patients. For those of you who come for my course, I will also explain to you the complications I've had with my obese patients. I will show you and I'll explain to you why obesity is a problem also. Okay, thank you. Are you into metrics or hypoxic? Yes, yes. I always use hypoxic burden right now. I do, yes. And T90 as well, yes. And arousal threshold. Thank you for saying that. Yes. So I am trying to find a quantitative measure of arousal threshold. You know the pump score, critical pressure, arousal threshold, loop gain, and muscle responsiveness. If we can quantify, as in put a number on each one of them, it'll be excellent. Then we can predict which patients will do better with CPAP and which patients will do better with surgery, right? Because the patients with UARS have a very low arousal threshold, because every time they have an airway collapse, they will wake up. They will wake up. But those patients with severe sleep apnea have a very high arousal threshold. They never wake up through all the long apneas. Amazing. We don't know why until today. Thank you very much. Any more questions for me?
Thank you. Thank you so much, Dr. Pang, for patiently answering all these questions. I would like to summarize a little bit before we close. So yes, as Dr. Pang said, we all must be conservative. At the same time, try and explain the disease process to the patient, make surgical diagrams as to what you're going to do. Also, tell them that there is no guarantee that you would cure their sleep apnea, whatever be the severity. And at the end of the discharge summary, it's always better to write that in case the surgery fails, then one must have to take an assisted airway device. So it's better to clearly explain the patient. And after that, if the patient gets excellent outcomes, they're going to be really appreciating. So sleep apnea is such a complex disease that nobody can guarantee. Yes, all these factors, all that you have taught today, Dr. Pang, I'm sure many of them have benefited. And there are many fellows in this group. There are a lot of people who have come for many fellowships under you. And the course in July also, I'm sure some of them are going to join from our group. And considering the time there, it's already very late for you, 11:30 p.m., I guess. You still sound energetic and very, very coherent and oriented. And that shows the passion you have for this sleep surgery. And
Thank you.
all of us as sleep surgeons, yes, there's also one thing, undercorrection and overcorrection, both are not good. Like there are people who come to me who have treated tongue base, they've done TORS, but they've just removed 10 cc's of tongue base. That's of no use at all. And overcorrection, yes, is going to hamper with, swallowing, like aspiration issues, and there can be other complications. So one must not give complications, only try and give some outcomes as to, at least improve their quality of life. This is what we all must, this is the take home message. And once again, thank you all for the, attendance. Nice to see you all here until now. And best wishes from WI to one and all. Thank you, Dr. Kenny Peter Pang, once again. Really appreciate your acceptance for the invitation. Thank you.
Good night.
Thank you.
Good night.
Good. Thank you all.
Good night.
Good night. Good night. Thank you, WA Executive. Thank you once again. Thank you, Ashima.
Thank you, ma'am.
Thank you, Ashima.
Thank you, Dr.
We have to
Chanchal.
thank you. It was very nice of you to bring Dr. Pang on board. It
Thank
was
you.
quite
was
a nice
wonderful.
talk.
Yeah.
And the question answer session, especially when he went through all the questions, it was
Yeah.
very nice.
Yeah.
Thank you.
Nice
Thank you.
discussion. Yeah. How many were there finally?
I think we
70
touched about 75, 80.
75, yeah, 75,
Okay.
76 at one time. Thank you,
Okay.
Dr. Arun, sir. He's
Kalpana,
still around.
Oh, sir. Good
Kalpana
evening. I didn't
Chanchal,
know you're
thank you
still
very
around.
much for
Thank
letting
you
me
for
know about
joining.
this wonderful lecture.
Thank you.
Let
Thank
me
you, sir.
let me share that
I just
last 1
messaged you
hour
thinking if you're
I
free.
really spent wonderful time.
Thank
That
you,
has
sir.
added lot to my knowledge, and we have realized the importance of upper airway and in relation to OSA.
Yes, sir.
It's a highly super specialized area.
So, with your
Right.
help, we want to collaborate more with other international speakers and surgeons all over the world.
Sure. I'm
Thank
so
you.
happy that your organization is really doing wonderful job.
Thank you so much. Saints.
Thank you, Dr. Archie. Thank you from Kazakhstan. Thank you for sending the link to join this lecture. Hope you'll send more links for us, and we'll be really happy to learn from you.
Yes,
you
I
again.
will. Yeah. Convey all my
you.
regards to the team members.
Bye for now.
But
Thank you.
Bye.
Good night.
Good night, everybody.
Thank you all. Good night.